with today's presentation. A few housekeeping items. Please mute your audio and turn off your video during the presentation, as we'll be recording this for future viewing. Please type questions using the chat function on Zoom. And at the end of the presentation, I'll lead a question and answer session with our presenters today. To claim 1 hour of CME credit for this session, please complete the evaluation of the session at the end of the webinar. Today, we're lucky enough to have Drs. Amber Gum, Asa Oxner, and Lucy Guerra join us to share their work in creating a COVID-19 positive confirmed clinic at USF Health. Dr. Guerra is a professor of medicine and director of the Division of General Internal Medicine at USF. She's an associate program director for the internal medicine residency and medical director for the Tampa General Hospital Specialty Clinic at Health Park and the Tampa Bay Crisis Center. Dr. Gum is a professor in the Department of Mental Health, Law, and Policy, and professor and psychologist in the Department of Internal Medicine at USF in Tampa. She conducts research to integrate mental health services and behavioral intervention into primary care and other health and social service settings, including establishing a patient-professional partnership to conduct research addressing trauma in primary care patients. Dr. Oxner is Vice Chair of Clinical Operations in the Department of Internal Medicine, an Associate Professor in the Division of General Internal Medicine at the University of South Florida College of Medicine. In the current COVID-19 pandemic, she has co-directed implementation of a new virtual clinic for patients across Hillsborough County who were positive for COVID-19 through partnership with USF's primary care departments, discharge coordinators at Tampa General Hospital, and the Florida Department of Health. Welcome, and thank you so much for sharing your innovation today. Turn things over to you.
Thank you, Ryan. All right, so we'll go through really 4 things today. I'll kind of explain for you guys how we set up the COVID positive clinic or the CoCo clinic, and a little bit about how it functions. And then I'll hand it over to Dr. Guerra and Dr. Gum, and they'll talk about integrating mental wellness into what we were doing and providing psychological first aid for the patients. So the first one is just really setting it up. And I think that the easiest way to look at that would be to just kind of see how we were able to create this pyramid sort of structure for staffing it. So we do it almost, the majority is on telehealth. We do some in-person visits, but at our peak, which we may be coming up to our second peak coming soon, but at our peak back in July, we were able to reach 300 patients per day on telephone, mostly telephone visits. And so really we would have 1 attending to 3 residents or an APP, and then each resident would be running a team of medical students, nursing students, APRN nursing students, and PharmD students. So any of those 3 colleges could have their students sign up to do CoCo Clinic as a true clinical rotation that they earned hours for and earned credit. I had to do quite a lot of evaluations for students to get caught up after the peak. But this was their only clinical rotation that was going during March and April when they weren't allowed, by the AAMC to be doing stuff. So each student would have 25 patients that they would reach out to on telephone. And then they would staff with residents, and then I would staff with all of them like once a day in the afternoon. And kind of some of the statistics down at the bottom are that our no-show rate / no answer, since it was telephone, was about 30%, and that's still the case now. We would follow up with these patients every 2 to 3 days. Unless they were super, super healthy, then we would say, don't call us, we'll call you, just because of volume. But most of them, it was every 2 to 3 days. Our average length of stay or period of time that we kept in touch with them would be 10 to 14 days before they were recovering. And patients at the time when I pulled the data, we had served over 4,700 patients. We're now closer to 5,700. And so then we had like standardized documentation. We had standardized assessments for them. And so we'll go through, and we had a treatment protocol as well. So we'll go through those things next. So really, it's nearly entirely virtual, and it was set up almost like a ward. So we had a workflow throughout the day. We have a huddle each morning with the people who are the students and residents who are going to be on for the day. We had the staffing structure as I described. We have a triaging system, which I'll show you what we use for medical comorbidities and vital signs to triage and score a patient. Then we did whole person assessments, which we had standardized documentation for. We set up treatment protocols, which we had to revise every month or so as more new data comes out. And Lucy's going to go over those for you guys. And then we had standardized kind of handouts and MyChart, like dot phrases that we would send to patients on MyChart of standardized advice given, like, can you spread this to your cat? And should I still get the vaccine even though I've been infected? We have to update that every month or so as well, because there's new FAQs that come out. But so we have that dot phrase and we give that to patients and their families. And then one of the cool parts about this is we also partnered with Tampa General Hospital to be able to have the highest risk patients get a specific device that they wear that is almost like an Apple Watch, but also it has like a probe on your finger for a pulse ox, and it lasts for 8 days continuously. And so, and then we get a dashboard of what it looks like, and it sends us a page to whoever is on call, sends it to one, on call number, and we pass that around to different students to take 24/7 call, to respond to the pages, look at the dashboard, call the patient, do an assessment, and escalate it if they need to for abnormal vitals. So we had that as part of this whole project as well. So the first question was, how are we even going to find the patients? How do they get to us? And so we made a referral order in Epic. And so when you get a positive test for COVID, we ask that the ordering provider, which could be from any of the urgent cares, from the emergency room, from ambulatory clinics, any of that, all the providers, we educated them on this referral order. And we said, if you order this, then it's going to go to our work queue, and we will schedule the follow-up with the patient 24 hours later, and then we'll keep them in our system until they get better. And so it could say where they're coming from: hospital, ER, clinics, transplant, our partner Moffitt Cancer Center, etc. And over time, I think we started the monoclonal antibodies in September or something. We added to the referral order does this patient qualify for monoclonal, yes or no? And if you scrolled down in here, it would list the criteria from the FDA. And so if they say yes, then our team schedules them for monoclonal antibody and puts them on the follow-up telehealth visit list. So we folded that in with the whole follow-up system. And we folded that into our treatment algorithms when that became available as well. So this really helps us make sure that we capture every single patient. And really, if the provider who tested them doesn't want to refer them, then they're that provider's problem. They have to be the one that follows them up and throughout this whole time instead of us. So it behooves each of the providers in the healthcare system to actually refer to us. So that's why we have such high volume. And so we really focused on making documentation and protocols that would be easy and scalable, because we knew that there would be a lot of patients coming through. And we had students from 3 different colleges that would be rotating through. And, really they rotate for some of them a few days, at most a few weeks at a time, until they're on to their next rotation. And so at the beginning, I was going blue in the face doing orientation over and over and over again until somebody had a brilliant idea of recording it and putting it on Canvas and making it a requirement that they watched it and verified it before they started the rotation, which saved my life. But, we had to standardize it as much as we could because their staff was changing so often and the patients were such high volume. So we did a few things to standardize it. First was we used this crafty triage system, which was originally devised by MGH. We modified it with adding a couple of things and taking out a couple things. The original one includes a lot of lab values, which we tried for a little bit, but we really didn't have lab values for the majority of our patients. So we took out the lab value stuff and we instead changed it to a lot of things having to do with vital signs in the past 24 hours, because that was something that we could get via a telephone call. We can explain to them how to check their pulse. We can listen to their respiratory rate. Most people were able to get hands on a fingertip pulse ox, or the sickest patients, we actually had a drive-through where we could schedule them to come pick up a free pulse ox. So we're doing that. And then BMI, we added in there that wasn't in the MGH one. So we kind of used the majority of the MGH one that was validated by them, and we modified it slightly to make it useful in a virtual setting. But basically, patients would get a point for any of these, and then we used that to stratify them. If they were 2 points or lower, then we considered them low risk, and we kind of ask them, we say, hey, do you want us calling you all the time? And if not, here's our phone number to call us back, but we can leave you alone. It seems like today you're pretty healthy and we expect that you're going to do well with COVID. If they were scoring 3 to 6 on here, then we said to them, we're going to check back with you every couple days for the next few weeks as you continue to get better. And then we gave them specific recommendations on prone positioning and things like that Dr. Garrett's going to show you for the treatment guidelines. And then if they were score of 7 or higher, then we really escalated that and we made a video visit for them. And that's when we started talking to them more about steroid treatment. We started considering putting them on those 24/7 vital sign monitors. So that's kind of how we would escalate if somebody is a score of 7 or higher on this. So it helped us to stratify our patients between the different options. And then since we're talking about standardizing, I know that there's a lot on here, but the point is that this is the documentation, the note that the students complete on each patient when they're calling the patient. So the stuff over on the left is like page 1 and then page 2. And a lot of it is clicking through, but you can see, it kind of asks them a little bit of HPI at the beginning. It helps the patient set some goals. What goals do you want for your symptoms? What barriers would you have there? It checks on a few public health things because we did this in collaboration with the Department of Health. So they wanted to make sure that they can self-isolate, that they can access food if they needed to, and that they would have transportation to the hospital if they started to decompensate. So we checked a couple public health things. Then we have the crafty score there. Then we check on their med list. And so that's really the kind of HPI and history, past medical history assessment. Then the next page started with a lot of the mental health assessment as well. And so Dr. Gum helped us to figure out if we really only want to spend 5 questions asking them how are they doing. These were the top 5 that we came up with, and what we could do in terms of referrals for the patients if they answered with a significant burden of mental health comorbidities to their COVID. And she'll talk in more detail about that. And then we had a standardized plan with our treatment algorithms that the students and residents discussed with patients, and our follow-up depending on their score. So, and we release all this info to patients on my charts so that they would be able to go back and reference it as well. So this helped us standardize the visit that the students had with patients. the treatments that they would be getting, other advice they would be getting, and our follow-up kind of prognosis plan as well. So this was our dot phrase that helps them be more and more standardized. So Dr. Gary's going to talk about the last medical part of our treatment protocols.
So just a couple things I'll mention that Dr. Oxner alluded to, but just to be clear, so we didn't necessarily staff all 300 patients as the attending. You know, we thought, well, we have senior residents that are going through the patients with the medical students. So if the senior resident, you know, made the decision that some of the patients didn't need to be staffed because they were ready to be discharged, then we went ahead and did that because, you know, we didn't have hours and hours to spend on rounding on all the patients. And then the other thing is when we say MGH, we're talking about Massachusetts General Hospital, because I think we kept using the acronym. So just wanted to mention that. So these are some of the standard things that we recommended, essentially with all of our patients. So we recommended that everybody take vitamin D, over-the-counter vitamin D. That recommendation was based on an article. It was a meta-analysis that was published in the Lancet. I believe it was a year or two before COVID, but it looked at 70,000 patients who had different viral illnesses. And it found that those patients that had normal to high vitamin D levels did better than those that did not. And so we thought that that was a pretty good recommendation to make. It was somewhat evidence-based, and it's not going to hurt anybody. And if anything, it would probably help. The exact role of how vitamin D affects viral illnesses is quite unclear, but still we did recommend that. I believe it was 4,000 or 5,000 units a day. We also recommended to everybody that they do prone positioning at home. So we would, you know, have the students go through this with the patient every time so that they understood what that meant, and tell them to do that several times a day, especially when they started to have respiratory symptoms. We also would, for some patients, we would recommend atorvastatin if they met criteria. And then if their oxygenation was less than 20 or 93%, then we would recommend prednisone that they would take. And then if they were hospitalized and again met certain criteria, they were placed on apixaban because we all know some of the hypercoagulability that's of a concern in COVID. And then finally, if the patient met specific criteria for the monoclonal antibodies, then we would also make those recommendations. And we're going to get to that in the next slide. So this is very detailed, so you can see like specific things that we said. Just a few things I'll highlight, and you can go back and look at this. We really tried to avoid antibiotics, including azithromycin and hydroxychloroquine, as something that was first kind of pushed in the early part of the pandemic. These were proven that, you know, not to be helpful, especially hydrochlorothiazide, or not hydrochlorothiazide, I'm sorry, hydroxychloroquine in, you know, once more data became available. So we did not recommend that at all to anybody. We recommended the prone positioning, like I said, and that was 1 hour for every 4 hours or so. If the patients felt dyspneic, they knew to check their pulse ox. And again, you know, we went through what that meant if their pulse ox dropped to below 93%. This was based also on the recovery study that we cited here, which then led us to prescribe those patients a course of prednisone. In some cases, sometimes prednisone was not available, or sometimes dexamethasone was not available because the pharmacies were getting overwhelmed with requests, so one or the other. But the standard thing we tried to use was dexamethasone, 6 milligrams daily for a duration of 10 days. And then those patients who had COVID-19 and were taking anticoagulant or antiplatelet therapy, we told them to continue their treatment. But for those patients that were non-hospitalized and had COVID, then we would not initiate those anticoagulants unless they had a specific history of like a deep venous thrombosis, or they were morbidly obese. And then those that did require hospitalization and were morbidly obese, sometimes in those cases, we would also put them on prophylactic anticoagulation, and they would continue that post-discharge. Aspirin was also recommended in some cases that we read about, but that was not something we did standardly because we did, or as a standard, because we did not think that that was very evidence-based. And then the last thing with regard to atorvastatin, we would start 40 milligrams daily upon diagnosis of COVID in those with guideline indications for statin therapy, again, who had underlying health conditions that would put them at greater risk for having a hypercoagulable related issue like diabetes and hypertension. And, we would include these, and sometimes as an alternative, we would use pravastatin because of drug interactions and things like that. So we tried as much as possible throughout the pandemic to really use what was out there with regard to evidence-based literature. So we weren't just pulling things out of a hat and giving patients advice that really didn't have any kind of scientific evidence to at least back it up on some level. So I'll talk a little bit about the monoclonal antibodies. The monoclonal antibodies that you're probably all familiar with that we're using here has been the bambolubimab. We call it the BAM drug because it's so difficult to pronounce. And we used the infusion criteria for patients who were in the moderate to high risk category. So those patients were able to receive this were those that had 10 days or less from the onset of symptoms. Literature has, shown that it's better if patients receive this particular antibody drug closer to when they first started with symptoms. So in other words, starting, at day 1 through 3 versus day 10. But we did include it up until day 10. And then they had to have one of the other moderate to high risk criteria. So those that we have listed here, a BMI above 35, diabetes, coronary disease, if they're immunosuppressed, age 65 or older, those with COPD, age 55 or older, coronary artery disease or hypertension, age 55 or older. And then if they were younger within the specific age range we have listed, then they would have to have these other things like sickle cell, congenital heart disease, large or a high BMI, et cetera. And so what we did was that in the order set that we talked about, we built this in because obviously we didn't have this at the beginning of the pandemic. And so then the order set became, not only are you referring to COVID clinic or CoCo clinic, but does your patient meet this criteria? And do you think that the patient then should receive the antibody? And so then that was great because then we could target those patients that the case managers could get a hold of, and we would be able to get them an appointment to get the antibody. And these types of antibodies can be done in an outpatient center. So we were able to actually do them here at the clinic we're in now. We set aside some rooms for that. And eventually that got moved to Tampa General to one of the outpatient infusion areas. And then the last part I'll just mention is that we're doing a variety of clinical trials. And so with Regeneron, for example, and so there were some patients that we would hear about, and then we would refer to the research coordinator, and they were able to contact the patient and see if they wanted to participate in a clinical trial for a drug that could be used with COVID, particularly Regeneron. And so it really was just another alternative for a lot of patients that were more than willing to be considered and participate. And then I'll let Dr. Gam take over the mental health piece.
Yes, so, and Dr. Oxner showed that it was in that 2 pages of documentation there. So we selected the PHQ-2 for depressive symptoms, the GAD-2 for anxiety symptoms, and then also, asked about alcohol or substance misuse. And a little bit later, I think we've got some more medical information here. And then a little bit later, I'll tell you more about kind of what then our wellness team did to try to support those patients who were more distressed.
Yeah, so this is a picture of that dashboard that I mentioned, and also the little device. So this is what they wear in their hand for 8 days. And this is just an example of the dashboard. So again, if their vitals fell, we could set the threshold ourselves. So we made the threshold that if their oxygen sat dropped below 90% for 5 minutes continuous, then we got a page. Or if their heart rate was above 110 for 10 minutes continuous, then we got a page. So either of those things would trigger a page to the team. They would log in and look at the dashboard for the actual vitals and also the trend, and then call the patient and do some medical triage and advice with them. We had we had a care plan for each of the patients who would go on this, because these were people that had high CRAFT scores here. So this was one of the examples, and it was staffed by the APRN students, but since they are students for, you know, their advanced nursing degrees, they actually already have RN degrees and are licensed in our hospital system. So like literally the nurses who were volunteering and doing this for school credit were also doing their day job of, they are RNs in the COVID ICU at Tampa General. So most of them, they would have like whatever, 3 12-hour shifts for their career in the COVID ICU. And then they would do this on a couple of other days per week to get credit towards their APRN degree. So it worked out really great because they kind of knew both sides and were actually quite efficient at handling these alerts. But they did have one of the attendings that they could escalate to as well if they needed to. And so we kept them at a staffing ratio of 1 to 6, as you would on a med-surg unit that you had tele on. So this is kind of what we were doing with that. And then this is a screenshot of some of, you know, it starts at number 10, but anyway, I just took a screenshot of our dot phrase with the advice that we gave to patients or families for some of the over-the-counter things they could do, when they can stop home isolation, when their other family members could get tested, things like that. So that they would have, because you can't dump all this in one telephone call and people can only absorb so much at one time. So then we sent this to them on MyChart so they could go back and look at it over the next few days as different things came to their mind that they needed to address. So we sent that along. But of course, one of the most common things that we have to address with them is all the time asking about prognosis, mortality, morbidity from this. And this is a slide that I use during the orientation for the students. It's at this point quite old data from March. It's like literally a different disease than it was in March almost, between the monoclonal antibodies and the steroids that we start using. And most of that treatment algorithm that Dr. Guerra went through, which is different, but nonetheless, the demographics still kind of hold true of who's going to be most likely to get hospitalized, have an ICU admission, and suffer mortality from COVID. And so we share this with students before they start their rotation so that they'll be ready to answer these questions from the patients and families when they're on the phone call. And then the last thing is, you know, as I said, our average length of stay is 10 to 14 days, but we do have patients who never really get better. And after 30 days, we dump them into a different clinic which we call the long haulers, because we really do have to turn over this clinic because it has such high volume of new referrals all the time. And so we had meetings with a bunch of other disciplines, neurology, psychiatry, etc. Went through the literature as much as we could on what is recommended for long haulers. And so now we have 2 phases of this. It's kind of changed. And again, this whole CoCo clinic has evolved monthly, depending on what is going on out there. But, you know, the long haulers is now its own separate thing. And we refer these patients. So we made protocols for long haulers as well. We refer the patients back to their primary care doctor, and we taught our primary care doctors in our health system about our protocols for long haulers. If they didn't have primary care in our health system, then we established them as new patients with mostly Dr. Guerra, but with any of the primary care docs at USF and Tampa General as well, so that we can get them into the algorithm for the long haulers. And this is some of the things that we recommend. It's split up by their persistent symptom. So some people have persistent fatigue, others have persistent dyspnea. And so the workup and treatment and referral would be different for all of those. Epic is putting these into I think it's called an order set for us so that we would just pick which is their predominant symptom, and then it would pull down the things and we would check off orders and referrals depending on their predominant symptom to make it even easier, so that right now we just have these posted up next to the computers, and the primary care docs just look over and reference it and type it in. But our IT team is trying to make it even easier for us to do that. But this was an example of some of the long hauler treatment algorithms that we taught to the whole primary care network here at USF. And so the last thing that I was going to go over before we get to the integration with mental health is a thing that we didn't expect when we started CoCo, but has kind of turned into one of the most exciting parts of it, I think, is that we've been able to leverage it as a pipeline for research as well. So a couple weeks into it, we added a question in the standard questions asking if patients would be willing to be contacted later for any research. And we found about 66%, 2/3, were willing to do that. And so we've been able to grow our research capacity through CoCo referrals, really. And I have a couple of slides split up into different types of clinical trials that we have gotten funded to do through CoCo. So we've been able to do some biobanking, some diagnostic studies to compare nasopharyngeal versus nasal versus saliva testing, to compare PCR versus spectroscopic machines, to look at other wearable devices to figure out if we can predict who's going to do poorly with COVID. Of course, the monoclonals, we're doing it as approved therapy now, but for several months, we were actually doing the Regeneron study, which was placebo controlled back then. We have an anticoagulation study that's placebo controlled. We have microbiome stuff, and then we have some long-term sequelae studies as well. So we've been, I mean, it's been so interesting, and we didn't expect it, but I'm actually very excited. And on Tuesday of this coming week, we're also going to start a Novavax vaccine study for which is an adenovirus vector vaccine instead of an mRNA vaccine, but we'll be able to give it to people because who are not 65. So it's going to be kind of fun to be able to offer that to other populations of patients. So, you know, it's been quite, and then we had some prevention studies as well. Anyway, it keeps going. So we've been quite interested in being able to leverage this as a pipeline to research that we didn't initially anticipate. All right, now on to the integration part.
All right, thank you, Dr. Oxner. So with this first part, and you can go to the next slide here, you can tell I'm in a different location. So what we, I think it was in April or maybe May, Dr. Oxner asked me about setting up wellness services, you know, anticipating that at least some of the patients were going to be distressed with their illness and other things going on. And so it took a little bit of time to, you know, think about and come up with the plan, but this is the basic model of how we have thought about putting together wellness services. And this is really fairly typical of how integrated care is done, you know, even pre-COVID, like depression care management and for anxiety and alcohol and things like that in primary care settings, is that these are different versions of stepped care models. And so a couple of references at the bottom that are just really nice references in general for integrated care. And so at the bottom, all patients receive universal screening and universal support. And so that's the part that Dr. Oxner and Dr. Guerra already described, the pre-screening that their students and CoCo team were doing, the reassurance that they were providing, and and of course sharing of apps and different resources. So we knew that some patients would need a little bit more than that. And so this middle tier, that's really the part that our wellness team did. And so with our brief intervention, we did a little more in depth of a screening and did a few additional telephone visits by one of our volunteers using the model of psychological first aid. And then if patients needed even more intensive support, then there were supervisors who were available to speak to those patients and then refer on for formal mental health services if that was needed. And so we can go on to the next slide. And I think we can move on. Actually, this is the pre-screening done by the CoCo team. And so this just lists out those questions there. And we can go on to, and these were identified, this was part of the script that the CoCo team had when those students were making those calls. So they would ask those questions, and then they, we had a few bulleted red flags of things for them to also be watching out for to make a referral to our wellness team. So, and if we move on from here, so this is their script, and again, similar to the other medical parts that they were doing, we tried to make things as easy as possible and straightforward and with this script. So, so that they could describe a little bit about our services. And we were pretty careful, to call this the and that they'd like to, they're here to talk to you and just to listen, trying to be as non-stigmatizing as possible, and setting the tone that we understand that this is a stressful time, and we have team members who would be happy to talk to you about that without using any kind of, mental health or psychiatric labels that might be stigmatizing for someone. Okay, so if we move on from here, so that was really the pre-screening and screening. And so if we move on, to our fourth objective here is a little bit more, okay, so once we got them, what did our team do? And this reminds us again that I'm talking about this middle tier of this model. And so if we move on, basically it was a screening plus psychological first aid. And I think the next slide shows us a little bit more about our team, and then we'll talk about what our team did. So I knew that obviously I wasn't going to be able to do this on my own, and I worked with two programs in our College of Behavioral and Community Sciences, one in our School of Social Work, the MSW program, and then in the Department of Child and Family Studies has a rehabilitation and mental health counseling master's programs. So these are the future licensed mental health counselors or licensed marriage and family therapists. So, so most of our volunteers were students in one of these two master's programs, or in a couple of cases, these were people who had their MSW and were registered MSW interns wanting hours toward licensure. And there were 4 supervisors, myself, 2 LCSWs and 1 LMFT. And so that was our team. And our team actually did not transition. We've had the same team for several months. So so if we go on, this will show, this is the screening that our team did. So we'd call the patient. We also had a very scripted protocol with kind of an introduction and then leading into this screening. This pandemic stress index has, and in the references at the end, you'll see links to several of these things. This is from the University of Miami, and it's a very quick checklist that we found helpful to just ask about were any number of different stressful things happening, concerns about other family members getting COVID, financial stressors, death Have you experienced grief, boredom, loneliness, just a variety of psychosocial stressors there. That's this brief checklist. And then you're probably familiar with the PHQ-9. And this coronavirus anxiety scale is similar to the GAD-7, except more focused on coronavirus. So that was our screening. All of this would get input into this Excel spreadsheet that would tally it up as the volunteer was going through the call. And then I'm sorry, I don't usually give people slides with a large block of text, but this is, I think, a very nice description of psychological first aid. And so, and I bolded a few words that I think are important. The goal is to help people to feel calm and supported. And really the foundation of it is simply caring and showing empathy. So really trying to understand that the person's perspective. Psychological first aid doesn't do labeling or any kind of mental health diagnosis, but really from a stress and coping framework that you're under a lot of stress right now, really high demands, people respond in a lot of different ways. How are you doing? And then brief conversations about some maybe additional coping strategies, what's worked for you in the past, just to help shore up coping strategies in the moment. So that's, really the core of psychological first aid. And we can move on here. These are resources. Again, the links for these are in the references. So these are the resources that we used as manuals. And then on the right, what you'll see is it's a free web-based training for psychological first aid. And all of our volunteers and supervisors went through that training. Okay, what we noticed was, on that checklist and in the conversations was that patients were reporting a variety of stressors. Some of them were related to the illness itself. Some of them were grieving. In one very memorable case, the patient had lost 3 family members to COVID, older and younger family members. And so some patients were grieving. There were several social concerns. Some of them had been isolated for a really long time, and the isolation was just getting to them. Of course, lost their jobs and had other kinds of financial impacts. One of our team members, Dr. Jerome Gallia, who's a faculty member in social work, used this phrase that really stuck with me, that for many of the patients, these were acute on chronic. So these were often, people who, we know that people who are more vulnerable, at least early on, of getting COVID, were people who still needed to keep working and things like that, and who had chronic stressors in their lives. And then COVID just added this additional layer of acute stressors on top of those chronic stressors. So I thought that was a really, really helpful phrase to kind of think about the stressors that they were dealing with. And so these are outcomes from our team as of about mid-December. So at that point, you can see not a lot of, many people are resilient, and many patients recovered, and they were managing the stressors, well on their own. We were referred 129 patients. You'll see there were some that we actually never contacted. And then there were also some that when we called, declined our services. Usually what they would say is, I'm doing all right now, and I don't feel like I need this. So that was a pretty good outcome. We had called and spoken to 82 patients, and you'll see there from those scores that that they were experiencing some anxiety and some mild depressive symptoms. And we did call patients 1 to a few times. And if you look at the bottom box, now this would not pass muster, with in terms of a large randomized trial that we might see published in our top tier journals. These outcomes are based on our team's impressions and the notes about how the patients were doing. So positive means that at the last note that the volunteer, wrote something like, patient reported better and they no longer feel like they need our services or any kind of mental health support. So of the ones we ended up talking, the majority of them did have a positive outcome. There were a few who were unchanged and one who worsened. One of the previous slides had referred to a pretty high suicide risk in that case that was diverted. And these patients, that patient was actually already had prior mental health services. And what we ended up doing with these patients was referring them, either to new or making sure that they connected with their existing mental health providers. So I think I've got one more slide, and then I'll see what Dr. Ochsner and Dr. Guerra want to add. I really like this quote. This is pre-COVID, but talking about integrating mental and physical and medical services, and that a fundamental requirement to do this well is having the people with the appropriate skills and attitudes. And I want to say that, this has been an amazing experience to work with Dr. Ochsner, Dr. Guerra, as well as, our wellness team, the supervisors and the students. Just everyone's attitude has been very passionate and committed. And, everybody has had the skills and has been really flexible and open to learning and also open to making adjustments, as the situation changed, and also maybe as we learned things that, the first way we tried doing things didn't work out optimally. And so it's been I've learned a lot just by this experience of collaborating with all of the team members. The infrastructure, it seems to be a really important part as well. Dr. Ochsner and Guerra showed you some of the protocols and the ways that things were set up, in Epic. So the technology, having even these videos for onboarding, a lot of checklists and spreadsheets, I learned from them and seeing what they had set up. And we tried to set our team up similarly in terms of using, technology and these strategies to help onboard and support the team. And that also seemed really important. And, it seems like when we put these things together that there can be a positive impact. And so one of our other supervisors said it doesn't take much to be helpful, and not to downplay any of the contributions, but that what seems to have happened is that as the leaders, Dr. Ochsner, Dr. Guerra, and some others, as the leaders put the infrastructure in place, got people, ready to work, then a lot of people chipped in a little bit of time and effort to really be able to serve a lot of patients. And so I'll stop there and see what you want to add, and then some discussion.
Yep, I think we can open it up to questions. One thing I was going to say is that Dr. Gum had this nice outcomes slide for the wellness part of the team. We are working on an outcome slide for kind of the impact of CoCo overall in terms of what our readmission rate was, what our mortality rate was, things like that. But I mean, with 5,000 patients, it's taking quite a long time. So maybe we'll get that to you guys when we can.
And I'll just add one thing too. I think it's important that, it's kind of neat. Like, we had a lot of faculty and students and healthcare workers that were part of this. And, I remember in one case, we had a cardiothoracic surgeon that had CoCo, and he was thrilled that a student called him. I mean, people just felt like somebody cares. Makes a big difference.
Thank you all so much for presenting. Really an incredible effort. A comment from Dr. Hagen here at UF. Really impressed with the effort here and the combination and integration of the medical and mental health components. One of the questions that came up was in regard to the medical device you all were using with the pulse oximetry. I think one of the questions I had was, how did that get funded? How did you get those? And what was the kind of protocol for their use? It's kind of a nice addition for some of those highest risk patients that you might be prone to send to the emergency department if you didn't have something like a continual monitor.
Yeah. So Tampa General purchased a bunch of those, and it's a rather lengthy setup. You have to like register a Bluetooth device and then pair it and make sure it works and log in the dashboard and stuff like that. So for patients to get that, they do actually have to go to the hospital where some of their nurses are trained to get it set up, and then they can go home. They don't have to be admitted necessarily, but like the devices are only existent there.
And it's the Massimo device.
It's called Massimo, yeah. And so, so Tampa General did that investment for us. And technically, so one thing we didn't talk about is that we're not really billing like anything for this. So if we were to do it all over again, what our hospital and university sponsors would like us to do is to bill the visits, right? At least as the telephone visits, because those are codes. And there are remote monitoring codes that you can also bill, that then this could be quite a more sustainable model. And we are actually talking with the operating officers and quality officers and stuff like that about eventually transitioning this from just COVID to doing a similar structure for COPD or heart failure or other discharges. But they really do want us to start billing then if we did that.
And we did build telehealth, like some of the patients that, you know, we
Video.
Video visit, those we billed all those. And obviously all the people that came in for the infusions and things like that, that we billed. And then, you know, we didn't really talk too much about it, but then all of the live patient visits, because we did get quite a few. I think we've seen 600 here over the last several months that were initially CoCo patients or admitted, or for whatever reason really needed someone to listen to their lungs or come in. And those, obviously we build those, you know, so.
Yeah, they're just mad about missed opportunities.
Right.
One of the questions that I had, I mean, it's just really remarkable what you've done in a very short time, I think, in thinking about the, you know, medical education component, both on the mental health side, and of course with the students and nurses you're working with, a huge interprofessional collaboration. Any, you know, suggestions kind of for those of us that might be trying to put something like this together that really got it off the ground as quickly as it seems like you were able to do it? And it sounds like you've gone through kind of monthly iterations and making some improvements and changes as you go. But you really, it sounds like, and I don't know if that is thanks to kind of the relationships you had going into the pandemic or the institutional support. What did you all feel was really key to that kind of rapid development of this program?
Just do it and then tell people what you're doing and ask them, you know, to support it. We didn't get as much support from Tampa General at the very beginning. Now we have quite a lot of support from them. You know, with the Massimo devices, and then they've actually hired 5 nurses to handle inbound phone calls for people calling us back and to do scheduling of the visits and of the monoclonals. So, you know, that's a big investment, 5 FTEs, but that wasn't until months and months and months in,
right,
when we had to prove that we were able to do this.
And early on, like I think the first or second week when, you know, Dr. Oxner and some of us had the idea about how we were going to do this, we weren't quite sure. We did get learning objectives to the medical students. I mean, for a while there, they weren't really doing much of anything. And so our primary care clerkship director, he was on board. So he helped us to write, you know, learning objectives, et cetera. And so it got very quickly approved. And then nursing was on board too, because they needed their nurse practitioner students to be able to get, you know, credit hours. So that we did very, very early on. And then at this point, you know, everybody knows the CoCo clinic now, all the specialists. I mean, you say CoCo, everybody knows what it is. And I think people have realized what a difference it's made in hopefully keeping people out of the hospital. Because you can keep them out of the hospital, that's going to help everyone. And then, including specialists who need to do, elective procedures and things like that. So I think that that's really made a big difference. Because at first I think people were like, really, is this really going to work? I remember when ASA first told me about it, I was like, I don't know that this is going to be sustainable. But we've been successful because we've had a lot of support and people have seen what it's done.
And we went and just dropped a couple of, figures and data on the CEO's office a couple times.
Yep.
Then eventually we got more support.
And Dr. Gum, what was the kind of, I don't know if you had that on one of your slides, in terms of what was kind of the average amount of time you all were spending with some of these patients? It sounds like many of them, it was a single call, on average. What was that like? It sounds like you've made an impact for a lot of those people.
Yeah. The first phone call took about 30 minutes, 20 to 30 minutes, if they were willing to do the screening questions and then chat, for another 15 minutes or so. And then the follow-up calls were shorter. They tended to be, how are you doing? You were going to work on this. How did that go? And so those tended to be about 15 minutes or so. I don't have a slide that actually has that, but what I do have is kind of the number of patients and the total number of hours. So in terms of actual patient contact, it was, for 82 patients, it was 73 hours. So a little bit less than 1 hour per patient, on average. Now, some people, it was one brief phone call. We did have a few, the ones who were more stressed, that might be 4 or 5 phone calls. And then again, a few of those did end up getting referred on, to mental health services. So, and I've talked to, and I've seen a couple of those in our internal medicine clinic, actually where Dr. Ochsner and Gara are right now.
Wonderful. Well, our time is up today. Again, thank you for presenting this wonderful program. I think is really inspiration, and kind of I'm still a little bit in awe as to what you've put together in such a short period. So thank you. I'm excited to hear additional outcomes as you all get them moving forward. Just really a wonderful combination of clinical care, medical education, and research as well. So we really applaud you for all this wonderful work. Thanks to all of those who were able to join us today. Remember to please evaluate the session and give some feedback to our presenters so that you can get CME credit. Hope everyone can stay safe and healthy and have a wonderful weekend. Thanks so much.
Thank you.
Thanks, guys.